Hey, I'm Todd Heffern. I'm an emergency medicine and EMS physician in Knoxville, Tennessee. Today we're going to talk about drug-assisted intubation, or kind of what was RSI, or rapid sequence intubation, or rapid sequence induction. First, why do we do RSI? And during this presentation, I will kind of use the terms interchangeably, just with the understanding that what we refer to as RSI is really kind of more moving toward this drug-assisted intubation, but I digress. So why RSI? It improves the intubation conditions, gives you a better view, and thereby increases your rate of a successful intubation. It also reduces direct trauma to the airway. The requirements for doing RSI is got to have medical director approval, both on the agency level as well as on the individual level. There has to be an initial training and recurrent training, and generally this is every 6 months to some extent. And finally, there's got to be a QI/QA process to evaluate and improve success rates and improve the education and understanding of why and how we do this. So when we talk about airway management, there's kind of three big picture things that we talk about with the A's and B's. Number one is oxygenation. This is ultimately, if you have to choose one thing to ensure as far as the A's and B's go, it's oxygenation. And your primary goal should be ensuring a SpO2 preferably above 94, but at least above 90%. The thing is, if you can use other means besides intubation and ventilation to maintain your SpO2 in a relatively normal range, you don't need to continue attempting intubation or using alternative airways or surgical airways. This can be as simple as using just a non-rebreather with high flow oxygen. Obviously, a bag valve mask with oxygen and ventilation. If you can do that, you can ventilate a person for years with a bag valve mask. Hand's going to get pretty damn tired, but it is possible. And obviously, instead of doing a full cricothyrotomy, you can use a needle cricothyrotomy as an alternative, both in children, obviously, but also in adults. Now, after oxygenation, our second goal is really ventilation. And this is the process of actually getting an adequate volume or an adequate tidal volume of air in and out of the lungs to essentially blow off your carbon dioxide. Now, again, if you can do this and oxygenate at the same time, that's great. But again, primarily, if we can just simply oxygenate people in the pre-hospital setting, hopefully you can get them to a destination, even a temporary destination, to get something more definitive done. Now, over time, yes, if we're just simply oxygenating people and not ventilating them, you're going to get a buildup of CO2 that's going to lead to a respiratory acidosis, and eventually is going to lead ultimately to a cardiac arrest once the CO2 builds up and the pH drops. Now, the third thing we talk about after your oxygenation and after your ventilation is airway protection. And again, starting with A and B, we first think about airway protection, but in general, even if you've got a questionable airway, if you can at least oxygenate them, and if you can definitely oxygenate and ventilate them, then you can forego having to put some sort of airway device in to protect the airway, at least temporarily. And now in the pre-hospital setting, and even in the emergency department to some extent, you don't necessarily have to rush and immediately intubate somebody as long as they're not having, evidence of definitive, aspiration of foreign bodies or vomitus or blood. So that kind of takes us into, A-01, which is our airway and O2 maintenance guideline. And if we start at the top here, and I will try and use the mouse because I'm still kind of learning to use the screencasting program. But if we start at the top here, obviously, you got your initial assessment of especially your A's and B's, and looking at the patient's respiratory rate and effort and adequacy, and looking at their pulse ox. Now, if they're doing okay on their own, their pulse ox is okay, you can just provide this supplemental oxygen and, work on other things if need be, or go ahead and transport. Obviously, if their respiratory rate is inadequate, their airway is not protected, then we kind of, initially move down here into the center into our basic airway maneuvers. And this includes, additional supplemental oxygen. This includes suction, physically opening airways, or using alternatives like an NPA or an OPA to assist, providing a channel to oxygenate and ventilate the patient, and ultimately using a bag valve mask to assist with ventilations. Now, if this is adequate, right here, you can continue using a bag valve mask or one of these, basic airway maneuvers, and continue to monitor it. And obviously, if it becomes inadequate, then you kind of cycle back in and reevaluate. Obviously, if they're obstructed, then we have a obstructed airway protocol, which we're not going to go into today. And if they're not obstructed, and you're not able to provide adequate oxygenation, airway protection, and or ventilations with simply a BVM and these other adjuncts, then we kind of go over here to the successful and inadequate portion. Now, first, in cardiac arrest, we insert, a blind insertion airway device, and whether that's a combi tube, a king tube, or an iGel, this can be inserted generally by an AEMT, and maybe starting to train lower credential providers even in cardiac arrest situations. If it's not a cardiac arrest situation, then we go down here to endotracheal intubation. And we'll talk about that in a few minutes. But essentially, you're going to get a couple of attempts at this. If you're successful, go on your merry way, continue treating your patient, and transport as soon as possible. After 2 unsuccessful attempts, then we go into the failed airway protocol, which we'll talk about in a little bit. So, what are the indications for drug-assisted intubation? Because the airway guideline can be used without needing any medications. Essentially, what we use drug-assisted intubation for is when you need a controlled airway, generally an endotracheal tube, but the patient is still reactive enough, be it alert or having other reflexes like a gag or biting down or coughing, that are going to make placing an endotracheal tube either very difficult or impossible. So, over the past several years, there have been some kind of national changes in how we approach RSI or DAI. One of the things is that with etomidate, which has been used for years and years and years in emergency medicine in the pre-hospital setting, we have seen some studies come up which have shown some downstream effect of adrenal suppression in these patients, especially in the ICU setting. Because of this, there's been a push to kind of move away from using etomidate for RSI. At the same time that all this data was coming out on etomidate, ketamine safety profile began to improve substantially. We got a lot more data showing that a lot of the concerns over ketamine were overblown. And so we have the kind of the downfall of etomidate and the rise of ketamine over the past several years. As far as the paralytics go, there's always been some risks associated with succinylcholine. And so because of that, we have made a move away from succinylcholine toward the non-depolarizing agents, which we'll talk about down the line. In the past, RSI was a very complicated procedure, and a lot of times there was a lot of pre-treatment medications, a lot of steps that made it difficult to implement, difficult to perform, and made a whole lot of people very uneasy about performing the procedure of RSI. And basically what we found is, again, over the past 5 to 10 years, a lot of the medications that we're using for pre-treatment, before we even get to a sedative or before we get to a paralytic, are really unnecessary, that there's not much clinical benefit downstream to these medications. For head injuries, a lot of times the pre-treatment agents of choice were either a dose of lidocaine or fentanyl. And basically we found that there's really no changes in clinical outcome using these. Atropine was pushed for years in the pediatric population to prevent bradycardia. Now it's only being used as a reactive medication. Defasciculating doses of paralytics, which was usually about 10% or 25% of a dose of a paralytic, especially succinylcholine, was used to kind of prepare the muscle. So there was no fasciculations because there was concern that it would raise your blood pressure and raise your intracranial or intraocular pressures. And basically, we've now gone to more of the non-depolarizing medications. So essentially, we took all these kind of pre-treatment steps out and to kind of help simplify the process, but also because there's not a whole lot of clinical evidence that they change any outcomes. So what are the contraindications? Essentially, the only absolute contraindication is some sort of known reaction or allergy to one of the agents used. Specifically with succinylcholine, there's a known history of malignant hyperthermia, if there's known hyperkalemia, which you're really not going to know in the pre-hospital setting, or if you have burns or crush injury, which is generally well over 12 hours and really probably more 24 to 48 hours out. In reality, even with succinylcholine, there's very few, if ever, any times in the pre-hospital setting that you're going to have especially a known contraindication. Now, that said, precautions. There's multiple states where when using these medications, we're going to change the hemodynamic status of that patient. And that can include dropping blood pressure or raising heart rate with some medications. So in any sort of state which is going to kind of have a tentative hemodynamic status, meaning somebody who's dehydrated, hypovolemic, where their heart is not going to be able to compensate for sudden changes in their hemodynamic status, you've got to be cautious with drug-assisted intubation. This includes pregnancy, obviously things like dehydration, septic shock, severe respiratory or cardiac disease. And finally, obviously with facial fractures or instability, even up to having just a massive big old beard that you're not going to be able to ventilate these patients, you need to be very careful, because as soon as you take away their respiratory drive, it's all on you to be able to oxygenate and ventilate them. So that takes us into our A-04, which is our drug-assisted intubation guideline. Now, starting at the top, obviously, we talked about A-01, which is our kind of airway and oxygen maintenance, providing supplemental O2 using non-invasive airway maneuvers or adjunct airways as needed, and then obviously just assisting the ventilations as needed. Preparing the patient is important. You want to be set up the patient to have the best possible chance at success with your first try at intubation, because the longer you go without intubation, the more time that you're taking, body's eating up oxygen, it's building up carbon dioxide, you're creating a more and more potentially unstable patient at that point. So you want to get the patient to the best possible location and position to be able to access the airway. Now, if that's taking them out to the back of the truck, or maybe moving them up to a bed, getting them out from between the toilet and the wall, get them somewhere where you have a little bit of room if possible. If this is a trauma patient and you're concerned about a cervical spine injury, removing the collar and having somebody hold the C-spine from below. And then obviously if you can, and if there's not concern over the spinal injury, then either extend tilting the head back a little bit to try and improve your visualization. Pre-oxygenation, obviously, and this is a really big thing, really pushed in cardiac arrest, but also very important before you just kill these people's respiratory drive. If you've got some time, and a lot of the times with drug-assisted intubation, this is not a crash airway. This is someone who's worsening in front of you, who absolutely can deteriorate en route to the hospital, but you probably have a few minutes. If you have this, throw them on high flow oxygen. Let's saturate that blood and that plasma with as much oxygen as possible, it's going to give you more time before they start to desaturate. You can do this with a high flow nasal cannula. You can do this with a non-rebreather. You can do this through the BBM. There's lots of options available. Obviously, ventilation. Now, if this is somebody who is pretty darn apneic and their CO2 may be high, you may want to be a little more aggressive. But in general, you really just want to assist their ventilations. Because if you start fighting against them, and especially depending on how responsive they are, if they start kind of fighting against you while you're trying to ventilate them, they're going to close their epiglottis, and that air is just going to go down in the belly. So again, assisting ventilation, but not something where you need to be, using very high volumes or high rates. Obviously, you're going to get IV or IO access to be able to give the medications, preferably 2 lines if you can, just in case. All these medicines can be given through an IO if needed. One thing that I would caution is that a lot of these medicines, a side effect is hypotension. So either the medication itself causing hypotension, or sometimes if you knock these patients out, kill their catecholamine response, they may drop their pressure very quickly on you. So I always recommend, unless you've got someone who floored pulmonary edema, to go ahead and start some fluids on these people. Assembling equipment, make sure you've got your laryngoscopes. You make sure you've got at least a couple sizes of endotracheal tube available. Make sure suction's available, and make sure you have your alternative airway devices, especially your OPAs, and you always have a backup airway ready. And that's generally going to be a King, an iGel, or a combi tube. Once you get everything set up, that patient is prepped and ready, then you're going to use your sedative or your induction agent. Now, in general, we're using ketamine, and we'll talk about it in a minute, but for right now, that's the preference. If we can't get it, our secondary is either going to be etomidate, 20 milligrams for adults, or Versed, probably 10 milligrams for adults. Ketamine is a very old drug that has been used for years and years. We got away from it in emergency medicine in the pre-hospital setting due to some concerns over increasing intracranial pressure and intraocular pressure. As we talked about before, we've kind of found over the past 5 or 10 years that evidence doesn't support that these effects have any significant clinical outcome. Now, it's different from the etomidate and Versed and other medications that we use, in that instead of blocking conduction by kind of attaching to the GABA receptor, the GABA receptor, ketamine kind of goes the back way and blocks an NMDA receptor, which is kind of the excitatory receptors in the central nervous system, and therefore decreases nerve conduction by blocking the excitation. It's a beautiful medicine because it has multiple different possible roles. We use it for pain control and providing analgesia as a kind of a secondary agent. It produces anxiolysis and amnesia. One of the nice things about it, especially with drug-assisted intubation and people who are potentially hemodynamically unstable, or causes tachycardia and hypertension much more than hypotension. But one of the downsides to it in this regard is that it also does not cause skeletal muscle relaxation, where in the past, when we're using a benzodiazepine like Versed or etomidate, you could give these medicines, the patients would relax, and you could potentially attempt intubation. With ketamine, that's probably not going to happen. Now, again, ketamine has a lot of benefits, and that's why we've really moved to it nationally in the past few years. Again, it does increase your heart rate and blood pressure, so you want to use it with caution in certain patients. These are relatively temporary effects and probably have little, if no, clinical significance, but you need to at least be aware. Some of the side effects that have been reported and are very rare include laryngospasm, as well as brief apneic periods if the medication is pushed too fast. The major side effect that we see is this emergence delirium, or this kind of almost living in a nightmare type state when these patients are waking up. Now, hopefully, our RSI patients are not going to be waking up. And really, this is more of a concern when we're using it for sedation or pain control. It does have a side effect of vomiting. However, usually that's further on down the line and more what we see with procedural sedation than with RSI or drug-assisted intubation. How do we dose it? Well, the induction dose is about 2 milligrams per kilogram. You're not really going to overdose people on ketamine. It has a very good safety profile. So in general, for adults, I recommend using 200 milligrams, IV or IO. Pediatrics, again, 2 mg per kg. You can probably go higher than that within reason. For sedation, generally, we're going to use approximately 1 milligram per kilogram. For pain control, we're going to use probably 0.3 to 0.5 milligrams per kilogram. It's decently rapid onset and will last, it says 5 to 10 minutes. It's probably going to last, maybe even longer than that in some patients. Now, etomidate was our drug of choice for years and years and years. It is kind of a little bit in a class of its own, but like the benzodiazepines and other medications that we use to kind of help relax people and calm them down, it activates the GABA receptor, which slows nerve conduction and thereby causing respiratory and mental depression. It can cause a decrease in blood pressure, and also may decrease intracranial pressure. Again, as we talked about before, we got away from etomidate because of the concerns of adrenal suppression, and as well as combined with the rise of ketamine. But in shortages, it may be used as a backup. And the dosing is generally 0.3 mg per kg. So essentially, practically everybody will receive, adult-wise, will receive 20 milligrams IV or IO. If you have someone who is very, very large, go up to 30. This lasts much shorter time frame than ketamine, though. And so if you give this, it has approximately the same duration of action as succinylcholine, but since we're using potentially longer acting paralytics, you've got to redose this fairly quickly, either if you're having trouble getting an airway, or once you have an airway, to provide the patient with sedation. Versed is kind of our classic benzodiazepine, which also, like etomidate, activates the GABA receptors and depresses the central nervous system. Again, it doesn't have any pain control properties. It's just a sedative. The dosing on this is going to be about 0.1 to 0.2 milligrams per kilogram. Generally recommend probably 10 milligrams IV or IO. And again, this can be repeated. It's got a little bit longer duration of action than the etomidate does. But again, something that you're going to want to redose relatively quickly. So after you've provided the sedative medication, we kind of go down to this kind of intermediate box here. A just says observe for low blood pressure and treat as needed. Generally, this is why I recommend a fluid bolus, and obviously watching for potentially bradycardia as well, and treating that with epinephrine or atropine. Going to B, it does say that if appropriate, you may attempt to place an endotracheal tube before giving a paralytic. Now, in general, I do not recommend this. The whole idea behind RSI is to use the paralytic drug to provide the best possible environment for the highest success rate for endotracheal intubation. Now, there are patients that you do not want to paralyze. If you cannot ventilate them or oxygenate them with a bag valve mask and they're still breathing on their own, you may want to defer the paralytic. These situations are rare. In general, the patient's probably either going to be so out of it that they don't even need any of the medications, or they're going to be alert and fighting and enough to where you need to paralyze them. But if you're on scene and you clinically feel like you're going to have a very high success rate without giving the paralytic, you're welcome to attempt it. Now, moving on to the paralytic. We've got 3 that we generally use. Obviously, succinylcholine, has been our go-to for years and years and years. But rocuronium and vecuronium have become more and more popular and more the standard of care. Now, again, succinylcholine, used for years and years and years. It is a depolarizing paralytic. Because of this, though, you can get fasciculations with it, and there's the side effects of potentially increasing your intracranial pressure, your intraocular pressure, as well as releasing potassium from the cells during this. This has kind of led to the relative contraindications with, any time you have increased intracranial pressure, like with TBI or a eye injury. It's contraindicated in various neuromuscular disorders, which you're probably not going to know about, or a history of malignant hyperthermia, which also you're probably not going to know about in the pre-hospital setting. The other, we always hear about it for crush injuries or burn injuries, but generally this is not till 24 to 48 hours after the injury. So unless we're talking about somebody who's been stuck under a rock in a backcountry for, days, it's not really relative in the pre-hospital setting. Really about the only true contraindication that may come into play with succinylcholine is the hyperkalemia. And so if you've got someone with renal failure who's got a wide QRS on an EKG, you need to be thinking about potentially using another agent. But again, these are all incredibly rare situations where if the only thing you have is succinylcholine, and you need an airway, it should probably be used. The dosing for sucks is 1 milligrams per kilogram in adults. So essentially, it's 100 milligrams. Historically, with etomidate and sucks, we've used either 20 milligrams of etomidate and 100 milligrams of sucks, or 30 and 150 for the morbidly obese. It's going to act, again, about a minute. Like the etomidate, it only lasts 2 to 5 minutes. There are cases, if you're having difficulty getting an airway, you may need to redose it. But again, we're not having these issues because a lot of the times we've been moving more toward rock and vec. So that kind of gets us to what we're using primarily as our preferred agent, which is rocuronium. It's a non-depolarizing muscle relaxant. We have had issues in the past kind of bringing it into the pre-hospital setting because it required refrigeration. What we found is that, like a lot of the other drugs, that the shelf life, even out of the refrigerator, really can be extended. But essentially, it's good for about 60 days out of the refrigerator per the manufacturer's recommendation. The dosing of this is just like sucks. It's 1 milligram per kilogram. So essentially, 100 milligrams is what you're going to give to an adult. It takes a little bit longer to kick in, but lasts quite a bit longer. Similarly, vecuronium or norcuron, another non-depolarizing agent, because it has a longer duration of action, we prefer using the rocuronium. Dosing for this is 1/10 of rocuronium, so 0.1 mg per kg. So instead of 100 milligrams, in adults, we're recommending 10 milligrams of vecuronium. In pediatrics, obviously the 0.1. Onset, again, is about 1 to 2 minutes, but potentially longer duration of action. So we're going to move on to endotracheal intubation now. The one key thing I will say is if you have a potentially unstable or an actively unstable patient, the person with the most experience on that scene should attempt to intubate that patient. If you've got hemodynamic instability, or you're having oxygenation issues or ventilation issues, then time is critical. The more time you sit there messing around trying to get a tube in, the more chance that you're going to have that patient's going to deteriorate very rapidly. Now, when we go in, this is what we're looking for. And obviously, vocal cords are going to be these nice pearly things. Anteriorly, you're going to have the epiglottis, which is hopefully moved out of the way. And posteriorly here, you're going to have the arytenoid cartilage, which are kind of these bulbous looking things. A lot of times, if you're not sure, if you can see the vocal cords, if you can find the arytenoid cartilage, again, the vocal cord should be anterior to that. A couple things just from having done this for years and feeling fairly comfortable with it. I generally recommend starting with a fairly large blade. Now, the biggest thing is finding what you're comfortable with. Now, there's two types of blade. There's the Mac and the Miller. The Mac is curved. It has a C on the end. The Miller is straight, looks like an L. The MAC, as you can see over here, kind of holds the tongue back and then goes between the tongue and the epiglottis here. With the MAC, you have to lift anteriorly to lift the epiglottis out of the way. With the Miller, it is designed to go straight in and to actually grab the epiglottis with the tongue to pull it out of the way. Now, a lot of anesthesiologists tend to like the Miller more. A lot of emergency physicians tend to like the MAC more. I personally agree with my colleagues and do like the MAC more. I think you get a better visualization. It's easier, at least in adults. There are situations though, and this is why we carry both, because if you've got a big old floppy epiglottis and you cannot get it out of the way, you can always attempt to use the Miller blade. In teaching how to intubate, you've got to understand what you're looking for. Obviously, the first thing is to get the tongue out of the way, and that's advancing the blade. You're generally going to start from the right-hand side of the mouth, advance back along the tongue and try and find the base of the tongue. Now, at the base of the tongue, you're going to find the epiglottis, and that's really the first thing you should be looking for, because if you can find the epiglottis, all you have to do is lift it out of the way, and the vocal cords should be right behind the epiglottis. So if you cannot find the epiglottis, there's one of two things. One is the tongue still in the way, which should be pretty obvious. Much more likely, though, is that you've gone well past the epiglottis and the larynx and are in the esophagus. And if that's the case, what you need to do is slowly back the blade out, and most of the time, either the cords in the laryngeal opening will drop into view, or at least the epiglottis will drop into view. And again, once you see it, then all you have to do is move the blade and lift the airway and tongue anteriorly to be able to visualize the cords. Once you've found the epiglottis and you've gotten it as much out of the way as you can, you're going to look for one of two things. Obviously, the cords. If you see the cords, great. Throw the tube down, throw a bougie down, get something between there. A lot of the times, though, your epiglottis is going to kind of be in the way, or you're just not getting enough of the airway out of the way to provide a full visualization of the cords. But if you can find the epiglottis first and lift it out of the way, a lot of the times you'll see the arytenoids here on either side. You may only see a little tiny bit of the cords, but if you can find those arytenoids, you know that those cords are right anterior to the arytenoids. So if you can simply imagine it getting cut off where the arrow is right now, if you can see that, you can try to pass the tube, but really this is where a bougie comes into play, because it is a beautiful adjunct to have, and I encourage you to use it even in regular intubations just to get used to it. It's going to be much easier to visualize that bougie passing past the arytenoids. And again, this is the gum elastic bougie. We store them straight in the emergency department. That's my personal preference. Obviously, in a jump bag, or if you've got a flight suit and you're keeping them in your pocket, a lot of times they're going to be curled up. Either way, again, what you're trying to do, you find those arytenoids. It's got this 45 or 30 degree angle on the tip of it. So as long as you maintain that anteriorly, so again, toward the ceiling, hopefully the ceiling at least, it will hopefully have a higher likelihood of going anteriorly into the trachea rather than posteriorly back here into the esophagus. You can kind of preload the endotracheal tube, and this is an option here where you load the endotracheal tube on, pass the bougie, and there's the little hole at the tip of the endotracheal tube that you can kind of feed it back through. Personally, I just stick the bougie in and then load the tube afterwards. Again, a lot of ways that you can do this. Biggest thing is using it, playing with it, getting comfortable with it, because this is a fantastic backup airway device.